Yes, I welcome all the participants, our mentor, Dr. Ajit Babu Maji, the Chief Coordinator, Dr. BNR Subudhi, and all the panelist presenters. This is a very good series we are already going through, and today's topic is very important because we need to understand the dynamics of the intraocular pressure. Dr. Rajul Parikh, we are known to each other for last over 15-20 years, and I know he is a very good teacher and very good glaucomologist. So due to his illness, he is not able to present himself physically, but of course, we will enjoy his presentation and learn a lot from this. And with these words, I again welcome you all to today's seminar. Over to the Chief Coordinator, Dr. Subudhi.
Thank you, President. So today is our 10th webinar series of ORTS. Let me share the screen.
Yes, it's coming.
It's okay?
Yeah.
So good evening, respected President EIZOC, our CSC, Dr. Sabyasachi Patnaik, mentor, Dr. Ajit Babu, and all my colleagues. I welcome you all. Today's session of EIZOC is as I told you, it's a ophthalmic resident teaching series number 10. And today's speaker is one of the famous glaucoma consultant of our country, Dr. Rajul Parikh. Unfortunately, just nick of time, he had some ill health for which he was not able to join. However, he has sent his presentation, and probably if he feels okay, he will join for 5 minutes after the end of the talk. So this is our series, this is our team. This is a team since last 3 months. We are continuing this every fortnight. We got a program, and this time we got a glaucoma program. Already we have covered gonioscopy, perimetry, and today we got intraocular pressure. It's dynamics and tonometry. And along with me, my coordinators, Dr. Ashok Nanda and Dr. Anurag Mishra. Of course, the major role is always played by our mentor, Dr. Ajit Babu Maji. Without him, probably this program would not have seen the lights. So thank you, Dr. Ajit Babu, always with us. And our Chairman Scientific Committee, Dr. Sabyasachi Patnaik, the dynamic always give me direction how to proceed.
Full screen karna. BNR. Full screen. Full screen.
Full screen is there?
No, I think slideshow is not coming yet.
Not coming?
Yeah.
Let's see again. Now, is it okay?
Yeah,
now?
it is okay now.
So, Dr. Sabyasachi Patnaik, our dynamic chairman scientific committee, always gives me direction how to proceed our programs like ORTS and RP, and along with our president and secretary, they're always with us in supporting this cause, the teaching series for the postgraduate students.
Sir, video is not opening. Can anybody help?
I'm sorry?
Rita here, sir. Video is not opening.
Your video, you.
Yes, sir, thank you.
Just wait. Achha, just let me. So today's speaker.
You exit and re-enter.
Dr. Rajul Parikh is our speaker today, and as you know, he is presently the director of Sriji Eye Clinic and Palex Glaucoma Care Center, Mumbai. He was the ex-consultant at Delhi Prasad Eye Institute, Hyderabad. He's got a lot of contributions in the WGA, the World Glaucoma Association, and he's got chapters in 17 books. He's the Society Editor, International Glaucoma Review, and 80 publications in peer-reviewed journals. He was the GSI Treasurer from 2005 to 2006. He was the West Zone Representative for the GSI from 2011 to 2012. He was the Member Education Committee, WGA, the World Glaucoma Association, and was the Joint Organizing Secretary for the annual GSI conference in 2011. He is also Associate Advisory Board member in WGA 2005-2018. And he is one of the section editor in EIZOC from 2007-2013. He is also the chief editor of Glaucoma Society of India guideline. So with all these academics within, probably will be missing him physically, but however we will be looking forward his presentation. Then of course we may in future we will invite him to again give a talk. Today's panelist, of course, Dr. Jennifer, as everybody knows, she is the director of Basmati Bansara Eye Hospital, Shillong, Meghalaya. She will be joining shortly. Dr. Sarmishta Behera, Associate Professor of Bimsar Burla. Dr. Pragati Khan is Professor at AIMS, Raebareli, Uttar Pradesh. And of course, Dr. Rita Das, she is from Odisha. She is the senior most consultant, glaucoma consultant, working at the Amri Eye Hospitals in Bhubaneswar. She has a vast experience. Today they are the panelists. And of course, today discussions, they have got 11 postgraduate students from different parts of the country. We can call it instead of EIZOC, it's a pan-India. Dr. Ankita Sharma, Dr. P. Pravina, Dr. Anjani Agrawal, Dr. Shreya Chakrabarti, Dr. Anita Sankla, Dr. Chitrangada Singh, Dr. Niharika T, Srija Singh, Sonali Singh, Dr. Manisha Agrawal, and Dr. Sarika Rath. So these are all the postgraduate students. They are with us today, and we will have a good interaction with these postgraduate students. So with these few words, once again I welcome you all. I request our Chairman Scientific Committee, Dr. Sabasaj Patnaik, to say a few words because he will be leaving shortly. He has got some other program today. So, Chairman Scientific Committee, Dr. Sabasaj Patnaik.
Yes, sir. Thank you very much, sir. I welcome all to this interesting program of EIZOC, that is Ophthalmic Resident Teaching Series. As our President has already highlighted the importance and the impact of this program, I have nothing much to add. Now I request our mentor, Dr. Ajit Babu, to start.
Thank you, everyone. Actually, the whole glaucoma section was going on well, except for today's sudden absence of Rajul. I thought he would be a very good presenter, as well as the discussion would have been much more useful for the postgraduates. But I expect both Pragati and Dr. Rita will fill the void. We have a recorded presentation of his. I expect that he will cover most of the intraocular pressure dynamics as well as the tonometer, both the aspects I asked him to cover. So that almost the clinical part, examination part of the glaucoma with this we will be finishing, because disc evaluation we have done, then fields we have done. Intraocular pressure now we are covering, and then the gonioscopy also we have done. Hereafter we may proceed with the other diagnostic modalities, followed by specific glaucoma conditions. With this, another 5-6 lectures probably will be there. But I think we should discuss the intraocular pressure dynamics and tonometry, the technique as well as the methodology, threadbare, and it is very, very important part for postgraduates in their clinical examination. We will make it today. Rajul must have covered the whole thing in his lecture, and anything which is missing, I think definitely we will discuss and fulfill the aspirations of our postgraduates. Thank you.
Now I think it's Mr. Anmol, our administrator. I request the administrator to share the presentation of Dr. Rajul Parikh.
Good afternoon, everyone. So I'll be talking about intraocular pressure and glaucoma. Now, basically, my talk is IOP measurements. So, till early 1900, the digital tonometry, the palpation tonometry, was the routine. Subsequently, the indentation, the skewed tonometry started, which was used till 50s. And in 1957, the Goldman introduced the applanation tonometry, which we routinely performing now also, Goldman applanation tonometer. Subsequently, the modification also came like NCT, the non-contact tonometer, which is also based on the applanation, corneal applanation, but uses the air puff to applanate the cornea. Now we know that glaucoma is the most major cause of blindness around the world. Is the second in some part and overall third most common cause of blindness in India. IOP is one of the salient risk factors for glaucoma. IOP measurement helps in diagnosis as well as monitoring the progression for glaucoma, because it's one of the causal risk factor for glaucoma management. So what I will be trying to talk in next 20-25 minutes is measurement, the errors related to the applanation tonometry, the role of IOP in glaucoma, the role of IOP in screening, in diagnosis and management, mainly target IOP. So we know we have digital, of course we should not do it. Shears, that is indentation tonometry, again out of date. Goldman applanation tonometer, newer non-contact tonometer, tonopen, and some of the other tonometers like dynamic contour tonometry, rebound tonometry, and I'll be talking about them in next couple of slides. So we know Goldman is the gold standard, is the most accurate at this point in time and is cost effective. But in last decade, the our knowledge about certain things have changed the perception about Goldman applanation tonometry. 15-20 years ago, we were not sure about this limitation. But after the ocular hypertension treatment study, we have realized that Goldman applanation tonometry do have limitation in relation to the corneal thickness and the acceptance of the refractive surgery, which makes the cornea thinner, and subsequently under correction of the IOP measurements. So these two things have changed our perception, and we have started thinking about finding the newer tonometers. So the limitation of applanation tonometer is one is corneal thickness, because when the Goldman formulated the applanation tonometer, the principle, he assumed that corneal thickness would be 520 microns. But we now know that normal variation is huge, and normal variation is huge. It can vary from 460, 470 to 600 plus, and if the corneal thickness varies, accordingly the IOP measurement would also vary. The measurement of static IOP, and the second important is in relation to cornea is corneal rigidity. So the rigid cornea would have a false IOP reading high, and less rigid cornea would have false low reading. So the newer tonometers, we have dynamic contour, they are not newer, they are there for it is more than a decade. Ocular response analyzer, rebound impact tonometer, and of course applanation is gold standard. So what is counter tonometer? So the principle is that it is based on the counter matching. The radius of the tip surface exactly matches the radius with the corresponding corneal segment assumes when the pressure on both sides of this part of cornea is identical, and pressure sensor integrated flush into the counter surface of the measured exit IOP. Okay. DCT is a street lamp mounted, it is commercially available. So this is how it looks. The radius of curvature of the counter tonometer is 10.5 millimeter. The radius of curvature of the pressure sensor is 1.2 millimeter. Weight is 25 grams. The advantage is direct, non-invasive, and it matches the corneal contour, and that's why it is less affected by the corneal properties, changes in the corneal property, especially corneal thickness, corneal elasticity. So this is the advantage. Now, since it is get less influence, theoretically it is more useful post-refractive surgery because it would not have IOP variation. Now, if you look the data, what it says that 50% less affected by corneal thickness compared to Goldman applanation, because the data shows now that only 6 to 14% of IOP variation attributed to the corneal thickness. So there are lots of other parameters which would important in the corneal IOP variation, and corneal thickness is only 14%, 10 to 15%. That's why DCT also would have variation in other, usually in the patient. And this is Verma's studies in 2007, huge numbers, and what they found that this was dynamic counter, this is Goldman applanation, and this is dynamic counter. So the variation was 2 to 3 millimeter. It is measures close to the actual pressure, but it still do get affected by the corneal thickness and other corneal parameters. So this is same study. You can see the fluctuation. So again you can see that as the corneal thickness increases, the IOP variation is still there in the DCT also, but less compared to the Goldman applanation. The second is ocular response analyzer. So it uses dynamic bidirectional applanation process to measure the biochemical properties. So now this is not corneal thickness, this is the biochemical properties, biomechanical, so the rigidity. So uses the rapid air impulses to apply the force on the cornea and electro-optical system to monitor the corneal deformation. So records the two applanation, one while the cornea is moving inward and one when cornea is coming back to its normal position. And this difference is calculated as a hysteresis. So due to these biochemical properties, the viscous damping, the cornea resists the dynamic air puff, causing delays in the inward and outward applanation event. These are two different pressure values. So the IOP-G is the average and hysteresis is the difference between these two pressure, inward and outward. Now advantage is that it provides a corneal compensated IOP. It also gives the hysteresis, that how much corneal dampening is there, how much corneal rigidity. And some of the studies too have shown that the normal thickness, the normal dimension glaucoma do have a less rigidity. But though we need more data on that part. The third is rebound tonometry, which is handheld, very easy to perform. It's based on bringing a magnetized probe into the contact with the eye and detecting is return to bounce motion with the sensing coil. The motion parameters of probe vary according to the eye pressure and can be used to determine the IOP. So probes are disposable, 20 millimeter. This is how the machine looks. Weight is the probe 11 milligram. It is 1 millimeter plastic cover to minimize the corneal damage. The commercially available is eye care rebound tonometry. It is a good correlation with Goldman applanation tonometry, though it measures usually 2 to 4 millimeter more IOP compared to the applanation tonometer. But handheld, very easy to use in the kids and uncooperative patients. So advantage is non-invasive, no need, it can be done in the fraction of a second. Reading are reproducible, easy to use in uncooperative patient, and as I mentioned that few millimeter more than Goldman applanation, but can be used on a day-to-day practice, especially for uncooperative people. So to summarize, these are two new machines. The eye care rebound tonometer is more commonly used because of its ease and can be performed in the children and the uncooperative patients. So this is about the different tonometers, especially new eye near tonometer. We also have discussed some of the limitation of the Goldman applanation tonometer. The second now we'll be talking about role of IOP. So we know now that glaucoma is a chronic progressive optic neuropathy where there are typical optic disc and visual field changes with corresponding nerve damage, where intraocular pressure is a causal risk factor. It is not part of definition, but it is a very important because at this point in time, the only thing we can treat is IOP. So now we have a different classifications. So ocular hypertension where the pressures are high but there is no damage to the optic nerve. And on the other hand, we have a normal tension or low tension glaucoma where IOP is the acceptable normal range, but there is a classical optic disc changes. So why this thinking? So when we collected the normal database, what we found that the mean most of the studies were 16 to 17 and two standard deviation was going upper limit was 21, the lower going was 6, two standard deviation. If you check the Indian studies, some of the South Indian studies we had done, the three standards was going to 23. So 16, so the upper range of two standard deviation, that means that covers nearly 97, two standard deviation would cover more than 95% of population. Up to 21 was the normal range. That's why the normal distribution IOP, the normal range came up to 21, and more than 21 is the ocular hypertension. But these studies have not taken corneal thickness into account. So now what does it mean now? So the basic question is that IOP causes damage, and we have enough evidence to show that increased IOP causes optic nerve damage. Usually the eye, if the two eye has asymmetric IOP, usually the IOP with more, the eye with more IOP would have a more optic nerve damage. If there is a trauma and the IOP is increased in one eye, then that eye only would have more optic nerve damage. So, and truly low means I am talking about 10, 11, 12, would rare to have glaucoma's damage. Even in the normal tension glaucoma, the IOPs are usually in the mid or high teens. So IOP do have, there is enough evidence that the eye is increased in IOP, there is an increase in the damage. If you look so much data, as the IOP increases, the percentage of developing visual field defect increases, and so the relative risk of developing glaucoma. And less than 16, relative risk is 1. IOP more than 30, the relative risk is 15. So as compared to IOP less than 16, if the pressure is 13, the chances of developing visual field defect is 15 times more. So IOP do have a relation with glaucoma damage. So there is a dose response relations. As IOP increase, the risk increases, and that is very clearly proven. So this up to 21 is normal range is for the normal population, but as IOP increases, glaucoma increases, so IOP have a direct relation with glaucoma development. Now what happens? Why damage with low IOP? So now if you look the population, IOP less than 22 is 20 times more common than IOP more than 22. Okay. Now risk with IOP less than 22 is only 1/6, but applies to 20 times more population. So if you look the statistics, then you are bound to have people, the normal tension glaucoma population around 50% as opposed to IOP more than 22. So this is the statistical jargon. In IOP, the cutoff of 21 is arbitrary, so we do not have to go by only IOP more than 21 is glaucoma. IOP is associated with nerve damage. IOP risk factor for nerve damage. Okay, this both IOP is associated, and IOP is very important role in glaucoma management. IOP is causal risk factor. This is all for last few minutes I have talked. It proves very clearly that IOP is a causal risk factor. There are other risk factor myopia, but myopia is not a causal risk factor, and we are not going to talk about it. Now there are other, since we are talking about IOP, and there are lots of talk about that, let's go and do screening in the population. So do IOP fulfills the criteria to go in a population for the screening? Now what are the criteria, the basic criteria that disease can be screened? It should be asymptomatic period, good screening test should be acceptable, treatment should be available, and cost effective. Now if you look, glaucoma fulfills majority of, there are more criteria, but I am talking about only important thing, and glaucoma do fulfill majority of the criteria, not all criteria. So the most important thing is now that asymptomatic, yes. Screening test, there are various screening tests, whether good or bad, I'm not talking now. Acceptable, yes. If checking IOP is a very basic thing, acceptable. Treatment available, cost effective, yes. Available now with generic, the cost has become effective and cheaper. But the test whether is good or not, that is the issue. So now this is positive predictive value, I'm not going to talk about it, but you have to remember very clearly that as prevalence increases, the chance of patient turning positive is high. Only 1 out of 16. So we'll be screening lot number of patients. Second, we'll be checking only IOP. You are not doing optic disc assessment, so you'll be missing significant 50% of population. Normal IOP less than 21 will be missing. So IOP measurement is not a good screening tool. Yeah, if you check cutoff have more than 25, more than 30, you'll pick up all glaucoma, but at the same time you will have huge glaucoma population missing. So IOP is a very good clinical sign, very good sign to monitor, but it's not a good screening test. So case detection, yes. Target high prescribe. So what we have to do, any patient who walks in our clinic for any problem, we must check intraocular pressure measurement along with gonioscopy, optic disc assessment. That is very important. And for non-ophthalmologists, we can teach them, our technicians, undilated disc, AC depth, but I'm not going to talk about it at this point in time. So now the role of IOP in diagnosis. So when we measure the IOP, let's say the technique 22, what we have to keep in mind that there can be errors. There's something called regression to mean. That's why we have to repeat the measurement, and we have to adjust with the central corneal thickness. I'll go one first. If the patient is squeezing, then the IOP can be falsely high, so that we have to take into account. The second is that if you check the multiple pressure, any parameters have a tendency to migrate toward its mean. So must take multiple pressure to see that what is the fluctuation and whether it is regressing to his mean IOP value. That's why we repeat the measurements, and we do corneal thickness and see whether patient has a thick cornea or normal or thin cornea. So normal cornea in Indian population, this is our study, but the Chennai study, population-based studies has shown that IOP, the corneal thickness is little thinner, around 510, not 520 in Indian population. But what you have to keep in mind, if the cornea is thick, the machine will measure falsely high pressure, and we will label them as ocular hypertension. And if the cornea is thin, then the machine will measure low pressure, and we may label POIG as a NTG. So the corneal thickness measurement is important in all glaucoma population. Now this is studies 5 millimeter mercury for every 70 micron. There are some studies have shown 3 millimeter mercury for 100 micron. So there are multiple formulas, and formula should not be used routinely because they will misguide you. So corneal thickness is important, but formula application is not important. If you get a 480 micron, please do not convert your 18 millimeter mercury pressure into 22 that we have adjusted for 50 micron by 60 micron by adding 14 micron for 1 millimeter mercury. Please do not do that. Ultrasound and optical, whichever you are doing, that's fine, but corneal thickness measurement must be done. Raised IOP must repeat pressure. You can check multiple pressures before you start the treatment, especially if the pressures are on the lower side, only in the high teens or early 20s, and gonioscopy is important. I'm not talking about gonioscopy, but gonioscopy is must in every patient. Do not rely on single IOP. Do not use IOP as a criteria for diagnosis, and for God forbidden, please do not use anything as an apprehension tonometry. Digital shield's are out. You have to use Goldman apprehension tonometer for all the patients. So we have covered measurement of IOP, role of IOP in glaucoma. We have covered screening for diagnosis. Now in management, to consider the treatment is working and whether it is acceptable. That is a question we have to answer. So Y21 we have discussed that cutoff is basically as a epidemiological survey is chosen basically to make search for glaucoma damage more efficient, but it is not to use in a routine day-to-day clinical practice. For that, target intraocular pressure measurement is must. So what are the definitions of target pressure? Now there are multiple definitions. The highest IOP in a given eye at which no clinically apparent nerve damage occurs. Now it's not as simple as it looks. It's difficult in a sense that highest IOP is given eye with no clinically apparent nerve damage occurs. That means which is the highest IOP where nerve damage would not happen. So this is theoretical. IOP at which rate of ganglion cell is age dependent, again we cannot calculate. So I will talk about that IOP at which the sum of quality of life from preserved vision and quality of life from not having side effect from treatment is maximized. So you do not have to go aggressively, you have to start one by one. You have to make patient, you have to take patient into consideration as a part of the management program. So now this is the graph. Now this is normal age-related loss. In glaucoma, this loss is exaggerated and patient can become blind at this age if the glaucoma started at this. Now you have a option of aggressively treating and making line parallel to this. So there is no glaucomatous loss. Or you can make sure that the treatment is just sufficient that the ganglion cell is little more than age-related loss, but it is still quality of vision is not affected much, and the quality of vision, the life is not affected by excessive side effect because of excessive medication. So this we have to, and this is not a one-day program. This is a day-to-day lifetime management program. So we have to monitor the patient and we can adjust the target pressure in subsequent visits. It's a dynamic process. Estimated based on the various facts, and we have to monitor. It is not a rocket science that it is 100% perfect. We have to admit and we have to know that, so we can always modify in subsequent visit. So we look existing optic disc damage, existing damage to the visual field, multiple baseline IOPs, and risk factors, other risk factors like thin cornea, young age, family history. Okay, all these are risk factors, and we are aiming for the target, not normal. Less than 21, 10 to 21 is normal range. We are not aiming less than 21 in every patient. Based on the damage, based on the field defect, we are targeting, we are deciding what acceptable range for that particular person is. That based, if the IOP is high, you can aim for the high pressure. You don't have to be less than 10, less than 15. If the initial pressures are high and damage is minimal. Okay, but if you look this data from Summers, what it says that if the baseline IOP, untreated IOP, 21 to 25, time to end-stage loss is 15 years, as opposed to more than 30 is only 3 years. So we have to keep this in mind, that we have to be aggressive for individual patient based on individual person's damage. So this is based on vertical. There are lots of formulas. Let's skip it. There are tables. Skip it. We don't follow that. This is theoretically the formula which we used, not in a sense that in a technical conversion, but this is how we usually practice our glaucoma patients. So target pressure is IOP multiplied by 1 I minus IOP 100 minus X plus Y plus minus 1. So basically it's a range. Now the Z is optic nerve damage, Y is visual field. Optic nerve damage and visual field damage, and Y is burden of therapy. So more the number of medications, higher the burden. This we have to keep in mind. So basically you use your optic nerve visual field damage, you look your baseline IOP, you can use your thought process that what is the burden you are causing to the patients, and you calculate your target. So I know that mild optic nerve damage, so if the pressure is, if I reduce 25 30%. In average high 20s, 21, 22 is more than adequate for this person. So as opposed to this patient is 20, post-vitrectomy severe advanced optic nerve damage, one maximum medical therapy. Here I want to be in low 10s and the calculation is 15 to 17. So this is how we use the patient's data to calculate target pressure. Again repeating myself, less than 21 is not acceptable for every person. Depending upon patient's baseline visual field damage, optic nerve damage and IOP, we decide the target pressure. These are existing damage to the disc, existing damage to the field, baseline multiple IOPs, additional risk factors. This is how you calculate your target pressure. Less than 21 does not mean that you achieve the target. Conclusion. If the pressures are going above 30, because it's disc damage, there is a inferior thinning, early superior arcuate scotoma, and is 80 plus. So it will be okay if we achieve the pressure into high 20s. The pressures are going to 26. Then I may start one medications once a day, or we can give long lasting beta blocker also once a day. Patient is not asthmatic. Third example, 60-year-old male, open angle, again 20 to 26, suspicious is early damage, few scotoma, inferior in thinning. So we can give one drop if the corneal thickness is normal. If cornea is thick, we can monitor, but usually I would start at least one drop because inferior thinning, early scotoma, young patient, relatively 60 years. So we would start one drops. So we can skip too many examples now. So the practical aspect, we have to remember that it is a range, not one number. And if you are in the within the range, then perfect. And if you are very close to the range, like if I have decided the IOP is 16 to 18 and I'm reached 19 from 25, then I would monitor. I would check multiple pressure in various visits before adding medication. So we have to be practical. So use multiple IOP readings in follow visit also. So you have to remember that damage is more at the higher IOP. Relation to the nerve damage is not linear. Damage increases faster at the higher IOP, but damage increases even if the target IOP is not achieved. So if you reduce from 30 to 20 is good, but if your target pressure is 14 to 16, then from 20 to 15 also is important. Though the rate of deterioration will slow down, but you have to control that. So it is important. As I mentioned, IOP is 13, target IOP is 15, 30 to 20 is as important as 20 to 15. We have to achieve the target pressure. So is a logical way to manage the glaucoma. There are evidence, if you look SIGIT study, AG study, there are evidence to support the concept. As AG shows that if the IOP is high, the glaucoma progression is little more compared to the IOP is low. So no hard evidence, but it is a very logical way to manage the glaucoma patients. Target IOP is important in managing glaucoma patients. Of course, there are limitations that because we don't know in IOP frequency of IOP fluctuates every minute, every few minutes. So which part of IOP is causing more damage, the lag timing detecting damage, how much IOP measurement we should do. So there are lots of limitations, but at this point in time, the multiple IOP measurement, application tonometry, is the way to treat glaucoma patients. So ideally, if we get a more sensitive tool using OCT or perimetry, some more sensitive tools where we can replace target pressure, but at this point in time, target IOP. So again, to repeat, target and normal is not same. You have to aim for the
Thank you, Dr. Rajul. I think you have given elaborate discussion on IOP measurement. So now I think Dr. Rita Das and Dr. Pragati to continue the discussion. So Dr. Pragati, give your comment, then we'll have some discussion. And Dr. Rita Das after that, and Dr. Sarmishta.
I request all the postgraduates to be video on and audio on, so that video at least on, so that the people can ask questions to them.
So postgraduate will not present the case?
No, no, no. They will not
Okay.
present the case.
Okay,
Based on
okay.
this presentation, you can ask questions to them.
Okay, Dr. Rajul has very elaborately covered the whole topic. The one thing for the residents, as he has said, the most important thing, if other instruments are not available with us, like the perimetry and all those things, intraocular pressure is very important to measure. And one should aim for the target pressure, not the normal pressure. Normal pressure is basically the statistical analysis by the various surveys that this is the normal range of the population. But the target pressure changes with every person depending upon which is the lowest pressure, which is not causing damage, which is not hampering the quality of life, as he has very well said. And that is not causing the medications used by him is also not causing the side effects. And the various types of tonometers available with us. And I think those are the questions which we will be interested in asking from the residents then, rather than me repeating the same thing. Is it okay, sir?
Yeah, yeah, sure.
Dr. Rita.
Actually, I would like to know how many postgraduates that using applanation tonometer themselves. That is very important.
Sorry.
All of you are using applanation tonometer or not?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Okay. Next thing I would like, just small thing, how you sterilize that tonometer, because that is also most
That is very
important. We have not covered
Tip of the
that.
tonometer, yeah, between the patients.
We use bacilloid in cotton dip bacilloid to clean the prism. So,
Initially, first case, how you are cleaning, and in between cases, how you people are cleaning. Because in this COVID time and in all every time, it's very important. That part most probably is not covered. That's why I'm asking this question.
Yeah, yeah, certainly. Dr. Anita Shankla.
Can I
Yes,
request
sir.
all the postgraduates
You
to
can
come?
tell whatever you are doing in the clinic, because most of this is very frequent in examination. Every patient we need to do. So how will you?
Any of the postgraduate student can answer this question.
Yeah, yeah. Someone will volunteer. So Dr. Anita can.
sir,
Yeah,
in
please.
between patients, we usually use sterilium soaked with cotton to clean and let it dry before we touch the patient's cornea again.
Okay. With sterilium. Anybody using 70% alcohol or hydrogen peroxide? Anybody?
We
How
are
many minutes or?
Yeah. Dr. Sarika. Yeah.
we are using bacilloid only, sir, even between patients and before starting to use the Goldman applanation tonometer, sir. We are asked not to use sterilium. If bacilloid is over, then only we use the sterilium. Otherwise, we don't, sir.
Okay. And take care, you have to dry the tonometer very thoroughly before applying it into the cornea. And another important thing, before doing the applanation tonometer, when you're using the anesthetic drop, ask the patient to close the eye. Usually people, they forget, they don't ask, they never instruct the patient, they keep their eyes open, the eyes are dry, and we get the false readings. So these are the small tips actually you have to take care of. So ask the patient after applying, whether you are applying 4% Xylocaine or proparacaine 0.5%, whatever anesthetic you are using, ask the patient to close the lid and instruct the patient thoroughly before taking. You will get the correct measurement. Otherwise, you will not see the Mayer. I am not getting the Mayer. People get tensed and they don't do it. So you apply the proper technique, and you do it in all the cases. Make it a routine. Thank you.
Dr.
Yes,
Rita,
excuse me, ma'am.
regarding
Yes,
your
sir.
Myers, once the prism is applied, what is the size of the
Yeah.
Myers or thickness of the Myers? This is also practically very, very essential while examining.
Yes, sir. It should
All
not
the
be very
precaution, what
thick.
all precaution? Pravina, can you answer
yeah.
what all precautions you are going to take during apprenticeship tonometry?
Yes, yeah. Someone can do that. Because these are all very practical tips. One video of good appellation, Myers, and how they need to
How much
that
fluorescein
take
to be
the,
used? Yes.
that is very, very essential in the clinic.
All the factors necessary
Pravina?
while doing.
Dr. Pravina, are you there?
Dr. Anjani Agrawal, she can answer. She can answer.
Yes, ma'am. Ma'am, you just with the fluorescent strip, we just touch. We never put the fluorescent strip there. We just touch and then we take the reading.
Which is the ideal position where you touched with the fluorescent strip.
Ma'am.
Where will you touch the fluorescent strip onto the eye?
Cornices.
Inferior bulbar conjunctiva.
Yes.
Inferiorly.
Yes.
Purely
Now,
bulbar
Anjali,
conjunctiva.
continue.
Yeah, not the fornices. Fornices, there will be lack of tear film will be there, so overstaining will be there. So then you will get a thick Myers where the reading can come false.
Yes,
Okay,
ma'am.
sir.
If the Myers are thick, reading will be more or less.
More.
More.
Okay, apart from the fluorescent strip, now next, what precautions will you take?
Ma'am, after staining, we will ask the patient to just look over the prism, and then we will just touch the prism over the cornea, and then we will look through it, and then we will see whether the inner edges of both the Myers are touching each other or not, and then we will see the reading, and then
The
we will
prism
apply
should not
the-
touch the precautions are the prism should not touch the lids or the lashes.
Yeah, it should not touch the lids or lashes. Eye should be open completely.
Eye should be open completely. Will you help in opening the eyelids? If the excessive palpebral aperture is there, will it lead to erroneous reading?
Yeah, it might be.
Might be or yes.
Yes, ma'am.
It will give you higher reading.
Yes, ma'am.
Yes.
If you're going to press too hard or there's a wider palpebral aperture, if the person is squeezing too much, if the prism is touching the lids or the lashes, all these things will lead to higher readings.
Yes, ma'am.
And then what next?
Ma'am, then we will see the Myers, whether they are both
Before
the inner.
that, if you have stained and it is overstaining has happened, what will you do? This is very practically possible.
Yes.
Ma'am, if it is overstaining.
Yeah, overstaining is there. Fluorescent overstaining is there in the tear film, and when you see its Myers is very thick and you cannot measure the apposition.
Can we wait?
What will happen?
We can ask the patient to wipe it off with a cotton buds.
Yes, sir. Gently wipe the excess with the eyes closed.
Yeah. With eyes closed.
It's fine.
Yeah, go ahead.
Another thing,
Sir,
sir.
Dr. Rita.
While under general anesthesia in children, particularly measuring the intraocular pressure, one should take care of the things which anesthetic drop medication the anesthetist is using.
He's giving.
Because
Yeah, please complete.
Anybody, because ketamine, it increases the intraocular pressure. So we should ask the anesthetist to give the anesthesia accordingly. So that part I want to emphasize, because sometimes in children they forget, but we have to remind them, and we should be careful in those cases. Not only measuring IOP under anesthesia or while doing surgery also, it is important.
And also the systemic history is very important, because they may alter the intraocular pressure.
Ma'am, I want to ask about the calibration, how we do the calibration.
The calibration rod is there. Has anybody seen that calibration rod? Because it has 3 points and has any postgraduate?
Yeah,
any postgraduate
let them
seen that
volunteer
rod?
first, and if they cannot answer, you can tell them. Yeah, this is very important. Actually, time to time, you need to calibrate the appellation tonometer. So, Dr. Manisha Agarwal, are you there? Dr. Manisha Agarwal, yeah. Come on to the video and try to answer this point. Dr. Manisha Agarwal, are you there?
Yes, sir.
Yeah, please try to answer this point. How to calibrate the appellation tonometer?
Sorry, sir, I don't know this.
See, it's very simple daily practice. Okay, Dr. Sonali Singh,
Yes, sir.
can you tell how to calibrate?
So there is
appellation
one.
tonometer?
So there is one rotation with numer of 0, 1 calibration. Which is equal to 1 is equal to 10 mm of Hg.
No. Maybe Dr. Rita, you please complete this. Otherwise, there will be no bigger problems. This is very important, and you may be asked. Okay.
Because one calibration rod is there. There is marks are there 2, 4, 6 like that, and you have to keep it in that position, and somebody has to demonstrate it actually, so that they can learn it properly.
No,
and
but
it's very
the
easy.
knob will be there, and you need to turn it according to the denoted on the rod. If it gives the plunger into forward or backward movement, actually. With the backward and forward movement at that pressure level, if it happens, then it is 0 calibration, and which is appropriate. If it is not happening around that pressure level, then it is, you need to adjust. So it requires a biomedical engineer to adjust the tonometer again.
Send that to manufacturer. They can do.
No.
Basically, always the
Usually biomedical
manufacturers
engineers
ask
will be
that.
there, and they can do that.
Yeah,
It's
they can
mainly
do
the
that.
spring effect that gets lost with time.
You can just check it out that they are in a straight line. These numbers are in a straight line. If the defect is there, then you have to call the manufacturer engineer.
That is in the first time when it is used. But on repeated uses, certain times it may go into wrong reading, showing maybe by 2 or 4 like that.
I want to say.
Yeah, please, Sharmishta, that's.
I just want to say that COVID has taken us more towards the no-touch technique, sir, and we are using NCT more.
Yeah,
but
NCT reading is, unless it is a normal reading, it always gives a false low reading.
Yes.
You may think that the IOP is normal and you may not change the medication. Okay, well, once you are getting a good Meyer, now how do you say that this is the exact intraocular pressure? You have to place the tonoprism onto the cornea. Now, how do you adjust it?
What is the end point, Chitrangana?
Yeah, end point, Dr. Pragat. You people should take over.
What is the end point to look for that this is the time now you should measure the intraocular pressure?
Yeah.
When you are looking at the Myers.
From the inner margins of the Myers, they should be coinciding with each other. And also like should be the Myers should be uniformly pulsating. So that is the end point where we should measure the IOP.
That is good.
If the Myers are of unequal size, what does it indicate?
There must be some irregularity in the cornea.
Oh, the corneal surface.
Yeah. What are the factors that leads to erroneous reading, especially of the corneal surface while measuring this? The thickness of the cornea, what does it? How does it affect the intraocular pressure?
Ma'am, there is 10 millimeter corneal thickness. We have.
Sorry, Anjani, you can repeat.
And with like 10 millimeter difference in corneal thickness, there is around 0.6, 0.7 difference in the IOP.
Not there in,
what will be the difference in the intraocular pressure if the thickness is due to edema or if the thickness is due to scarring?
Ma'am, in corneal edema, there will be false decrease in IOP.
And in scarring, it will be?
Scarring, it will be more.
It will be more.
And also, ma'am, the other reasons are astigmatism against the rule or with the rule astigmatism. With that also, the false, if it is against the rule, then false increase in IOP, whereas in case of with the rule, there will be false decrease in IOP.
Dr. Shrija, you are there? Dr. Shrija? Dr. Niharika? Niharika, are you there? Manisha Singh? Sonali Singh?
Yes, ma'am.
Okay.
Sonali is
Achha, you are Sonali. Okay. In which conditions actually do you look for the diurnal variation, which is very important that you should measure the diurnal intraocular pressure?
Ma'am.
Anyone else?
Can anybody else answer?
Ocular hypertension, ma'am.
Okay. And
if you're suspecting
normal tension glaucoma.
In normal tension glaucoma, and also in these two conditions, plus also while near setting the baseline intraocular pressure, you have to look for the fluctuations. How much is the fluctuation which is going on throughout the 24-hour period, and what is the peak time for the rise of IOP? Because you have to calculate the target pressure and you have to set the timing of the eye drops which the person has to use. Therefore, these things are very important.
Yeah.
Dr. Samishta, you can ask something?
Mr. has asked a question: how effective is Tonocare to measure the IOP in children?
Okay.
For you only, Dr. Pragat.
For me to answer why Dr. Samishta is asking me.
No. I
don't know.
It's only for my knowledge. It's only for my knowledge.
No, it is for everyone's knowledge, madam. You think it's your knowledge only.
No, because we have to take the patient to the for evaluation under anesthesia and all. Instead of doing that, can we measure it using a Tonocare?
You can use the Tonocare, but it is said that as Dr. Parikh has also told about this, that this gives the reading in collaboration with the Goldman applanation tonometer only when it is in the normal ranges.
Okay.
Beyond that, it is also affected by the other factors like any other applanation tonometer. So
Okay.
you'll get the idea just like that only.
Thank you.
But the thing is, it is no anesthesia is required because it is a very tiny plunger, sensor tip over there, and therefore it can be easily done, and the time required for the calculation of the IOP is very less. So it can be easily done in those patients.
Okay. Thank you.
Dr. Rita, are you there? You can ask questions. Dr. Rita?
Yeah, she's there. She's there, but you are muted, Dr. Rita.
One
Please
question,
ask.
Dr. Pragati.
Yeah.
How
Yes,
does NCT non-contact tonometries are effective in measure the intraocular pressures? You know,
So non-contact tonometry is good because it is actually preventing the transfer of the infection. Otherwise, the intraocular pressure, as far as this study goes on, the Goldman applanation tonometer is still the standard one.
right?
Yeah,
right,
that's what we do. Regularly, we can do with NCT. If the pressures are borderline or higher, then you transfer.
Then we can shift for, yeah, then we can go for the Goldman applanation tonometer. Otherwise, for the normal
So that-
routine screening
yeah, yeah.
also, and for the normal routine, we can go for the non-contact tonometer.
It is very quick, so that all the patients you can check with NCT.
Yeah.
Someone's mobile. Routinely you can quickly check the pressures in busy OPD.
Routine, yeah.
Whenever there is a higher pressure which is coming, then you cross check it with appellation tonometer.
Because in routine busy OPD practice is very difficult to do the appellants in all cases.
No, that's why this is the guideline we can use.
Yeah.
So
Sir, it is
There's a
a
question for Dr. Rita from Dr. Anita.
Yeah, she's
Ma'am,
asking.
she has asked multiple IOP measurements, when and how frequently. Ma'am, you can answer.
Actually, diurnal variation in our setup where we don't have postgraduate students, it's very difficult to take the diurnal variation in all patients. In those cases, what we are doing, we are asking the patient to come in different times of the day. So multiple pressure readings at different times, and we're in all cases we are mentioning the time at what time we recorded the pressure. So we can know at what time the peak is there and at what time is not same in 100% of cases. It's not high in the early morning. Some cases they are different. So accordingly, we have to prescribe the drop. Which drop at what time we have to give. Suppose beta blocker we are giving in a single dose beta blocker, preferring to give at morning dose, or prostaglandin in the evening. So, but multiple recordings we have to take to know when the peak is there, when the trough is there in the IOP, so that we can monitor, because all cases are not same.
Yes, ma'am.
Yeah, Anita, yeah.
Yes,
Hello?
ma'am. Understood. Yes, ma'am.
So,
Hello.
Dr. Rita, we had in our time somebody we used to do water drinking tests. We asked the poor fellow to drink 1 liter of water, and we used to record the intraocular pressure. So, I don't think any practice nowadays we do those tests.
We are not doing that anymore.
Yeah. So,
no, sir.
But I think that can be done. That is effective.
Yeah.
It takes a lot of time.
Yeah.
Sir, actually, doing the dilated eye examination is most important, and gonioscopy. What I want to emphasize, gonioscopy, and emphasizing people to do perfect tonometry and analyzing the visual field is sufficient enough, because people that do not dilate and they do not do the good slit lamp examination properly, seeing the iris convexity, antechamber depth, and other ocular findings, very early stage pseudo exfoliation things, they're missed. And doing gonioscopy in proper condition is very important. What we are missing.
Yeah, we have
Those
covered
things
all that, Dr. Rita. We have
Dr.
covered all the
Ankita
aspects of, yeah, that's why we are stepwise, we are progressing. We have covered the gonioscopy, disc evaluation we have covered, and then field analysis. And this is intraocular pressure is the other aspect, clinical aspect. All these are in the clinic only.
So clinical, actually, we have to ask our PG students routinely, because it takes hardly few minutes only to take the applanation tonometry.
Yes.
So we should emphasize them to do it themselves.
Okay.
All PG students, they should do it themselves.
In the examination room, during the exams,
so that they can do it very comfortably, sir.
So even during
you will be
exam,
comfortable.
the
They will not be
can do.
comfortable.
During exams also they can do.
They will start shaking, and the Myers will be shaking.
No, sir. If somebody does it every day, so that he or she will learn from his mistakes.
Yeah,
like
yeah, 100%, 100%. Routinely, they should do it. And the initial 10-15 cases, actually, the faculty should verify them, whether they are getting the good Myers or not. Getting good Myers is not so easy.
Yes.
How they describe, good Meyer getting is not easy, and it requires a practice, good practice.
So like breath holding of the patient, they should, they will learn from their mistakes only.
Yeah, 100%. There is no doubt about it.
Ma'am, breath holding is there, but that is why it is being said that repeated IOP measurement should be done. Maybe in the initial stage, the patient is apprehensive and he's doing all these things. Breath holding is there by the resident also and by the patient also. Can I ask a question, sir, from the resident?
Yeah, please.
Yeah,
Dr. Ankita Sharma, are you there?
Yes, ma'am.
Ankita, you
please
tell
come
me,
on to the video, Ankita.
do you,
yes,
if it
Your
is a
video is
proven
not
case
on.
of primary open angle glaucoma,
yes,
will you still do gonioscopy or not?
Ma'am, could you please repeat the question once?
A proven case of primary open angle glaucoma, the patient is coming repeatedly to you on subsequent visits after some time. Will you go for gonioscopy or not, and why?
Ma'am, if we have done gonioscopy, we should do gonioscopy at least once. Like initially, we have evaluated everything. We have done the intraocular pressure, we have done the fields, we have checked the disc, we have even done the OCT. The comprehensive evaluation should include a gonioscopy. But as such, ma'am, like the angle structures won't change that much over time, or the width of the angle won't change that much over time. So even if once the gonioscopy has been done and it has been proven to be an open angle, I don't feel that we should go for a gonioscopy again.
No, you should repeat it. Because subsequently, sometimes centrally the chamber may appear deep, but in the periphery, it may lead to maybe the lens is increasing day by day. In the subsequent visit, it may be leading to angle closure glaucoma, or there may be something else may have happened. So it is better if you repeat the gonioscopy on the subsequent visit. Maybe you might miss it, and there is some damage in the angle. There may be iridotrabecular touch. Maybe later on it might have happened and you might miss it. So it is better to repeat the gonioscopy, even if it is a proven case of primary open angle glaucoma. And what advice do you give while instilling an eye drop? What advice do you give to the patient?
Anti-glaucoma medications.
Anti-glaucoma medications.
We should exercise punctal occlusion so that means the topical absorption, it is better, and it doesn't go into the systemic circulation, means the bioavailability of the drug increases.
Okay, so what else?
Apart from this, like the frequency, we need to ensure that compliance is there with respect to the frequency of a particular drop. Like if we are advising brinzotam, it has to be given thrice a day. So the patient should be putting it that many times. That
what
one
else?
drop. And Ma'am, like, are you like trying to ask for something particular which I am missing out on?
Yes, yes.
Ma'am, at the same time, it should be applied every day.
That is there for the glaucoma medication. Approximately the time should be the same. There should not be frequent blinking of the lids, of the eyelids after installation of the eye drop. There should not be too much of drop should be instilled into the eye so that there is overrolling over the lids. That should be immediately wiped off, and there should be punctal closure, because there are so many side effects related to the anti-glaucoma medications, related to the dermatitis also, skin pigmentation also, that should not be there. It should not roll over the lids, over to the cheeks. That is very important.
Thank you.
And the person should not keep staring also. After instilling a drop, lightly close the lids. Do not squeeze them tightly, nor keep them open.
One point actually I want to tell. First thing one should ask who is putting the eye drop, because they're elderly people, and maximum time when we are seeing the IOP is not controlled, first thing we should ask who is putting the drop, because old people, they themselves they tell ki they are putting the eye drop. And when you ask, you demonstrate how you are putting, they have tremor, they have all those things. So drop is not properly instilled. So before adding on or substituting the drop, the proper history should be taken who is putting the eye drop.
That is the most important thing actually.
Can you discuss with regarding the target pressure a little bit more with the residents?
Yes, sir, we can. Ankita, I can see you over there.
Yes.
Okay. You tell me, what actually do you understand by the target pressure? Though it has been discussed, but still I'm asking you.
Yes, ma'am. Target IOP is that pressure at which the vision of the patient is preserved, the quality of life is good, and the various symptoms of glaucoma, they are not manifest. So that is the safe pressure at which which should be the target for the medications, so that the patient is able to maintain a good quality of life.
Okay. So how do you decide on what factors this target pressure depends on?
The target pressure, it should, because we are taking into account, like, there should not be damage. So we need to take into account the different parameters which we consider in damage, like the optic disc damage,
okay,
the amount of field damage,
okay,
and then, yes, ma'am, basically these two things.
No, there are plenty of other things which should be taken into consideration while setting the target pressure. Anybody else can contribute, any of the residents? Other residents can contribute to this question, to the answer to this question.
Are you there?
Yes, sir.
Yeah. You can
Sir,
attend. There is no how.
Sir, we will check the optic disc status, the visual fields advancement of the patient at the time of presentation, and also the patient's baseline IOP to consider the target IOP of that particular patient.
Okay, what else? Take into consideration the age of the patient, the life expectancy of the patient, the baseline IOP, the added up systemic problems the person may be facing. All these factors, they have to be taken into consideration. If the patient's life expectancy is less, he's an old patient, why add more and more drugs and add to the problems he is already having? This is how you set the target pressure apart from the severity of the glaucomatous damage. That definitely.
And number of medications also, I think, has a role.
Number of medications have a role. How many have to be added? What is the maximal tolerated drugs? Any resident can answer. Maximum responsible medical treatment. Reasonable medical treatment.
Not more than 3 drugs to achieve the target IOP. It is the maximal tolerated. Like, if with 3 drugs also we are not able to achieve the target IOP, then it is considered as the maximal medical therapy, and after that we have to resort to surgery.
Okay, these things actually differ from person to person, or what we can say is we can go for a combination drug so that up till 4 eye drops we can add. So that if we are using 2 eye drops with two combination of each, that the compliance will be better, and we have achieved added the maximum treatment what we can. And then even after that, if the patient target pressure is not achievable, then you have to go for surgery.
When do you
decide? So, sir.
Yeah, please.
No,
go.
sir, please continue, sir.
No. You are the primary.
Okay, Dr. Praveena is there? Only 3-4 residents are there. Okay.
No, there are other residents there.
Ankita is there, no? Yeah, I'm seeing Ankita.
Sarika is there.
Anusha. Please come on to the video. We can ask you people. Sarika is there. Sarika.
I forgot the question. Looking at the name of the question, I forgot the question.
I will ask. How do you suspect low tension or normal tension glaucoma in a given clinical scenario?
Sir, in normal tension glaucoma, in consecutive visit and along with the diurnal variation IOP, if consecutive checkup shows normal range IOP along with the optic disc changes or field changes, we'll call it normal tension glaucoma, sir.
Okay. So how do you
if
investigate?
A person is ocular hypertensive, having pressure of approximately 25 millimeter of mercury with no field effects, no optic disc changes, will you start with the treatment, Sarika?
Ma'am, we can, if consecutively the pressure is high, we can start with one drug anti-glaucoma medication.
We'll start with
what
one
is
drug.
Ocular hypertension. Now she has asked almost related to ocular hypertension.
Ocular hypertension is high pressure.
No. Let us not use the terms. She said the fields are normal. There are no changes. 25 millimeters of mercury. Will you start the treatment or not? And then
we can ask the patient for follow-up, sir, 3-monthly follow-up to keep to check the further optic disc changes or any field effects.
That is the answer. Correct. So when you go for normal tension glaucoma definition by itself, this will come. Okay, she indirectly asked.
Also, if possible, if you go for the diurnal variation, even if with this pressure, if the difference of the diurnal variation is, as we have already studied, it's approximately 7 to 8 millimeter of mercury, you'll have to start the treatment even at this level of intraocular pressure.
Okay.
Agreed.
Or if the patient is one-eyed, or the patient has lost the other eye due to glaucoma, or have a family history of glaucoma, you have to be very careful with not starting the treatment. Maybe you'll have to start the treatment at this intraocular pressure also.
Yes, ma'am.
Okay, sir, I think we have asked enough questions. Dr. Rita, you can.
Dr. Rita. Yeah, we are managing the show. Yes.
Yeah.
Yes.
I don't leave so easily any of the graduates. They need to study.
Let us ask the students to ask questions. Let us ask the students to ask questions. If they have any doubts, anything.
Yeah, that is also there. But let Dr. Rita ask 2-3 questions. Then we will go on to them. They will ask questions and we will answer.
Yes,
Dr. Rita.
Actually, you have to, along with the intraocular pressure, you have to mention the central corneal thickness. Central corneal thickness, because if it's more, falsely it will give rise to high IOP. And one has to see other systemic or ocular risk factors. Suppose with 25 IOP, no disc or field damage, but positive family history of glaucoma. Or pseudo exfoliation is there, so one has to think for treatment, and one has to think either monocular trial should be given or both the eyes should be treated. So accordingly, it's individualized. One has to discuss with the patient and with the patient family members. It's a team effort. It's not a individual, whatever I'll give the medication. You have to explain, your chair time should be more. So
what is monocular therapy, Dr. Sarika?
Yes, sir.
What is monocular therapy? Trial.
Sir, therapy for one eye, not both eyes. If one eye tension is higher, they can start with one eye and check the IOP regularly.
How long?
Monthly follow-up is done, sir, for those patients.
Dr. Rita, please complete that because you have told no monocular trial. That's why I asked the question to her.
So usually after 2 weeks, after 4 weeks, we call the patient to see what is the result of that drug. If it's acting, then or we are why we are treating the patient. If the patient is getting the benefit or not, that's why we are treating. So if it is drug is acting, because suppose latanoprost, 30% are non-responders. So if it's not acting, then why should we give? So to know whether the drug is acting or not, we give the monocular trial, because in 1 month, suppose the other eye is requiring treatment, it will not be hampered that much. So we call the patient, usually after 4 weeks, we call the patient to see the drug effect.
At 1 month, you will see whether the response is there or not. That is the, at least you should give for a month. Yeah. Any other questions, Dr. Rita? From your side, anything to discuss?
Dr. Shreya?
No.
Dr.
Shreya is
Shreya?
there?
Dr. Shreya?
Shreya is not joined, I think.
Okay. Dr. Ankita Sharma?
Yes, ma'am.
How do you measure the intraocular pressure after LASIK surgery?
We can use the Pascal dynamic contour tonometer for that.
Why do you have to use that?
Ma'am, because as had been discussed by sir also, that it is 50% less affected by the CCT as compared to Goldman's applanation tonometry. So that can be one advantage which can help in choosing that as a modality for post-LASIK patients.
Okay. If you don't have that, can you go for some other thing? Because everybody is not having this dynamic contour tonometer.
No.
Can you use
This was covered actually.
Yes,
ma'am. Like whenever there is any irregularity of cornea, like this is also basically a change has happened in the corneal contour after LASIK. So in those cases, tonopen can be useful.
Tonopen is usually used in those areas where the
art corneas is used for.
Where the LASIK surgery has not been done. That is in the peripheral part of the cornea. And you compare the pre-tonometry, pre-surgery measurement and the post-surgery measurement in the peripheral zone.
Okay.
This is how you can measure it.
Sir, one thing is that post-VR surgery, sir can tell the thing, post-VR surgery, IOP measurement, one should be careful.
Yeah.
Is it a question or you are giving a suggestion?
Suggestion, sir. They have to keep it in their mind. I'm taking intraocular pressure measurement in a post-vitrectomized eye, or this is silicon filled eye, or this is the thing.
The ocular rigidity will be different actually. It's not only that, these people mostly they are myopes. And this scleral rigidity will be low in these patients actually. So we need to consider that as one of the reasons. And where Dr. Rajul Parikh has nicely covered, NCT will give both upper and lower this thing. So the rigidity also can be calculated with this.
The rigidity is taken care of by ocular response analyzer.
Yes, ocular response.
Okay.
So shall we pass it on to postgraduates to ask questions for us?
Yes, sir. Yes, sir.
I think.
Yeah, please. Please, sirs, please ask your questions. Sirs and madams.
Yes, anybody has any doubt?
Yeah.
Anything, you can ask
Now it
questions.
is your turn to ask us. Put us in difficult situations so that we'll go back and read.
Sir, like
That's
in the
what I
case
do.
of,
Yes.
That's what I do. If I cannot answer, I will go and read.
sir, in the case of ophthalmos, like we are taking the children for examination under anesthesia. So in that case, like the anesthetic agents, say causing hypercapnia, that can, the blood gas keeps changing and that can affect the IOP. So like we are doing that measurement under anesthesia. So is it not affecting, like how accurate is that? Like for these congenital glaucoma
Yes,
patients,
yes,
we're
yes.
taking the IOP.
It is
So
good. She has covered very, Dr. Pragati, I think you have covered.
Dr. Rita has answered this
Dr.
question
Rita
before
has
also.
covered
Yeah.
very briefly regarding the ketamine only. But if you see the anesthesia, at what stage you should measure? At REM stage, we should not measure. Usually it gives false high readings. And in deep anesthesia, it will give false low readings also. So we should be careful in measuring under anesthesia.
And sir, even if the pressure comes out to be normal, the congenital glaucoma, the disc ophthalmos is not diagnosed only on the IOP reading.
IOP readings, yes.
Apart from the measurement also, because of the changes which are taking place inside the eye, the IOP may not be higher as compared to the size of the cornea, the length of the eyeball, the optic disc changes. There might be more of diagnostic value rather than the intraocular pressure.
Alone.
Yes, sir.
Intraocular pressure alone. Certain times even the disc changes may not be there. The enlargement of the cornea may be neutralizing the intraocular pressure, as well as disc will not, the changes do not transfer to the disc. So these all three parameters are very, very essential. One, corneal diameter, intraocular pressure, and disc changes. And in ophthalmos, certain times, once you control the intraocular pressure, the cupping can reverse.
Yes, sir.
Only in congenital glaucoma, that is very peculiar, and you can expect a reversal of the optic disc.
Can any of the residents answer why this is happening? Why there is reversal?
The scleral rigidity is less in the pediatric eyes, and means the labina cribrosa, that is actually the part of the sclera only. So if the scleral rigidity is less in the pediatric eyes, and this axial length will also.
This is a question for you to read from the books.
Okay. Any other question? Dr. Sarika, Sonali, Anita, Anjani.
Sir, what about the transpalpebral IOP measurement? If like in a close eye, can we, other than digital? Digital
is that only, that is the least preferred method.
In case of corneal ulcer or anything there, or where, how can we measure?
Corneal ulcer, yeah, you can measure, no? Non-contact tonometer, it is for that only. Without touching this thing, you can still measure with NCT.
But sir, in that case, NCT doesn't give a reliable IOP. Like most of the time, we can't measure in corneal ulcer even with NCT. I have tried myself in a few corneal ulcer patients, and for those patients, we have like I still have a doubt like what to do.
Excuse me, in a case of corneal ulcer, when you're seeing thinning is there and you're anticipating it cannot tolerate the normal intraocular pressure also, you can add the anti-glaucoma medication in that case, because or you can see the other eye also. If you want to know whether is pre-existing glaucoma is there or not, you can examine the other eye, the optic disc. From there you can get an idea why you will measure with the applanation tonometer.
No. Here is the question is that whether we can measure it accurately or not. It will not. You cannot measure accurate intraocular pressure, but you will get a rough pressure where it is raised or not raised. That's it. So,
Sir, my personal opinion, in an ulcerated patient, better not to measure the intraocular pressure till it is in an active stage.
But at the same time, even if you want to measure, like they have asked,
then you can go for the non-contact tonometry. Yes, sir.
That is non-contact tonometry is the answer. Okay.
Or in this case, digital.
Measure. Yeah, digital is okay, but digital is the last answer they should
last
give
answer
the examination.
Because in road traffic,
NCT is the answer.
Okay, sir.
Only clinical judgment in the rest.
Yeah. Next. Any other?
So, I think they have.
Questions are over or exhausted?
Yes.
Okay. Over to Dr. BNR.
Okay. So, before I close and we begin the vote of thanks, let me ask our Mr. Anmol to share the video of our host. Mr. Anmol, are you there? So, first of all, I must thank Dr. Rajul Parikh. Unfortunately, could not join in spite of his ill health. He could call me twice or thrice in the afternoon to say about his problem and also how to share the screen with his presentation. So I thank him and I look for again maybe some other episode. We will ask him to join with us, have a good discussion. And of course, today's episode was really wonderfully managed by two of our stalwarts, Dr. Pragati Garg and Dr. Sita Das, with the support from Dr. Sarmishta Behra, our panelists today. So probably if I had not taken this panelist, probably it would have been incomplete webinar today. So thanks Dr. Pragati and Dr. Rita and Dr. Sarmishta completing this webinar nicely and really wonderful. And I think all my thanks goes to our mentor, Dr. Ajit Babu, coordinating the things, and I think he's a true moderator, I would say. He was moderating the whole session from beginning to end. And my thanks goes to all the postgraduates.
Postgraduates, yes.
Some of the postgraduates could not join, maybe due to some difficulty they could not join, but however, whoever joined, they really wonderfully interacted with our experts, and I look forward. Please do come and join in all our programs. So, so that it will be very interesting webinars and subsequently. So, as already mentioned, we have already finished the diagnostic, clinical part. Then probably we will be going to the diagnostic part next few episodes. And the last but not the least, the audience, some of the audience, and also our host, Enter Pharmaceuticals, who has provided the platform today. So, thank you, everybody. Have a good day. Good night.
Yeah.
Thank you,
Special
sir.
thanks to both Dr. Pragati and Dr. Rita.
Yes.
Really, you helped us today because we were in a fix whether to cancel or postpone this thing. But because unless the speaker is there physically, it's very
yes,
difficult.
Sir. It becomes difficult, sir.
Because the postgraduates will feel neglected, which was not there today. Actually, they participated actively and we nicely.
Sir, thankfully, we lived up to your expectation. Thank you so much, sir. You are a wonderful moderator. And thanks to Dr. Subidhi sir for inviting me. Thank you so much.
Thank you all. Thank you all.
And to my
Thank you, sir.
co-panelists, they were wonderful.
Yeah,
And
yeah.
of course,
you,
the
sir.
students,
Thank you, sir.
by interacting very well, we liked it.
Right.
Thank you. Thank you, ma'am. Thank you, ma'am.
Ultimately, whatever we aimed for, high interaction with postgraduates.
Thank you.
Thank you, sir.
Thank you all.
Thank
Good
you.
night.
Thank
Good
you.
night.
We also enjoyed.
Yeah, yeah, yeah. Right.
Good night.
Thank you, sir.
Good night.
Thanks, everyone.
Good night, sir. Good night. Good night.
ये बज रहा है और मेरा